Hello there, and welcome everyone to Mastering the Matrix Fiscal Year 2026 IPPS. My name is Lynette Tome, and I'm an RHIA, a CCS, and a CDIP. And my role is Client Success Educator. And I am joined here by my colleague Beth, and I'll allow her to introduce herself.
Hi, I'm Beth Ford, an inpatient evaluator rules consultant, here to assist with today's presentation. I'm so glad you could all join us here today.
Great, thanks. So let's first dive into the objectives. So we're going to be talking about the changes to the coding guidelines, shifts in ICD-10-CM and PCS, MS-DRG updates and their impact on reimbursement, new technology add-on payments or NTAPs, and we'll go over some practical strategies to align compliance, documentation, and revenue integrity. And with that, I am going to go off camera to reduce distraction. And we have a poll question. So I'm going to hand that over to Beth to go over for us. Thank you.
Great. So our first polling question asks, what is your organization's top priority in response to the fiscal year 2026 IPPS changes? Is it revenue cycle adjustments, clinical documentation improvement, quality reporting compliance, staff education and training, or we're still evaluating the impact? And we'll just let this tally for a few minutes. Okay, it looks like we can probably end the poll. And it appears that the majority tend to shift for still evaluating impact, with a close second followed by revenue cycle adjustments and then staff education and training. Okay. Back to you, Lynette.
Great. Thank you so much. All right. Let's see what we can find in our overview. So we will first start with just the changes. So in 2026, both ICD-10-CM and PCS recorded greater net changes compared to 2025. So you can see the 2025 code set at the top, 2026 at the bottom. Our diagnosis codes, we had a net increase of 459. And our procedure codes, we had a net increase of 129. So first, we will cover the changes to the official coding guidelines. So we have some key guideline changes here that we'll just cover at a high level view here. So the first one is 1A7 about punctuation, which there is a revision containing clarification on comma use in the alphabetic index. So they are going to be used to convey alternate verbiage, essential and non-essential modifiers, as well as serve as an alternative to and or. Now remember, this is in relation to terms in the alphabetic index, not necessarily terms in the medical record. And then 1B14, documentation by clinicians other than the patient's provider. They added firearm injury intent. We have a new coding guideline, 1B20, about multiple sites coding, providing clarification of when to assign individual versus multiple. And several chapter-specific guideline updates, including those related to HIV disease and HIV positive status, diabetes in remission, obesity, and hypertensive heart failure with other heart conditions like cardiomegaly. And then we do have just a very slight revision in the examples for the ICD-10-PCS new technology general guidelines E1A and E1B. So first we will look at changes in Chapter 1 for certain infections and parasitic diseases, where we have multiple changes throughout Chapter 1A on HIV infections, including new and revised guidelines for reporting B20, for reporting on sequencing asymptomatic status, inconclusive serology, testing encounters, HIV in pregnancy, and antiretroviral medication management. Okay, this first one is a brand new guideline, and it is going to be the first guideline in Chapter 1, C1A2A, that says if the term AIDS or HIV disease is documented, or if the patient is treated for an HIV-related illness, or is described as having any condition resulting from the patient's HIV positive status, code B20 for HIV should be assigned. So this is great clarification for use of B20. And then we have the second guideline is a revised guideline with just some addition of verbiage regarding patients admitted with HIV disease for an unrelated condition, where code B20 would be reported as a secondary diagnosis. And then, of course, the reason for admission, that unrelated condition, would be sequenced as the principal. This guideline is renumbered. We will just go over this really quickly. It's not necessarily new. There's just some revision in the wording, talking about HIV positive or HIV test positive or similar terminology. When there is no documentation of signs or symptoms of the HIV-related illness, then we would code Z21 for the asymptomatic HIV infection status. And this guideline regarding inconclusive HIV serology just has a revision here saying that we will use code R75 for documentation of inconclusive HIV serology. And then we have revised wording and numbering for this guideline that I'm going to go ahead and cover because this is also important and ties back to that first coding guideline that we talked about. Patients with documentation of a prior diagnosis of an HIV-related illness should be coded to B20. Once an HIV-related illness has developed, code B20 should always be assigned on every subsequent admission. Patients previously diagnosed with any HIV illness should never be assigned to that R75 for the inconclusive evidence or to the Z21 for the asymptomatic infection status. And then we do have some revised wording and numbering regarding HIV in pregnancy, childbirth, and the puerperium. So when a patient presents during this period with documented symptomatic HIV or HIV-related illness, assign a code from subcategory O98.7 for HIV disease, complicating the pregnancy, childbirth, and puerperium, followed by code B20. And then if a patient presents during that period with asymptomatic infection status or is just HIV positive, we will still assign a code from subcategory O98.7, followed by a code for Z21. Now, just of note, O98.7 category codes are CC diagnoses and can impact that MS-DRG or APR-DRG. And we do have a revision regarding encounters for HIV testing, where a patient without signs or symptoms is tested for HIV. We'll assign code Z11.4, encounter for screening for HIV. If a patient presents with signs or symptoms of HIV for testing, code the signs and symptoms. An additional code for the counseling may be assigned. And then code Z11.4, the encounter for screening for HIV, should not be assigned if HIV signs or symptoms are present. So this is some additional clarifying verbiage of when to use encounter for screening and when to code the signs and symptoms. And then we have the last HIV-related guideline is a revision regarding patients on antiretroviral medication. So if a patient is documented with HIV positive status and is currently managed on antiretroviral medication, we will assign code Z21 in the absence of any additional documentation of HIV disease, HIV-related illness, or AIDS. So there were some extensive guideline revisions and renumbering in Chapter 1. The next, Chapter 2, has a revised guideline for neoplasms, for encounters, chiefly for administration of anti-neoplastic chemotherapy, immunotherapy, and radiation therapy, where if the reason for the encounter is more than one type of therapy, code Z51.0 and codes from subcategory Z51.1 may be assigned together. We do have a new guideline regarding the new code for type 2 diabetes mellitus without complications in remission, which is code E11A. This is to be assigned based on provider documentation that the diabetes mellitus is in remission. And of course, if it is unclear, we will query. For example, the term resolved is not synonymous with remission. So, of course, the reason we have changes to the ICD-10 classification is for the use of new diagnoses based on new medical treatments. So, for diabetes mellitus in remission, patients usually achieve this through significant and sustained weight loss. And remission from type 2 diabetes is not a cure, and it does require continuous maintenance of weight and lifestyle. So the rise in performance of bariatric surgery and the recent use of those weight loss medications, the GLP-1s, has created the need for this new code. Okay, this obesity guideline is not new for IPPS 2026. It was effective in April, but I thought I would go ahead and cover it as it is a new guideline. So this is talking about obesity in category E66, which has codes related to the cause as well as the effects. There are other codes in other categories that also are related to obesity. And then it goes on to discuss obesity class, where obesity class can be used with other codes for obesity in other chapters, chapters 4 and 15. The exception is when both class 3 obesity and morbid obesity are documented. Only a code for class 3 obesity would be reported at that time, since it is more specific. We also have a revised guideline in the circulatory system. So this has some edited phrasing regarding hypertensive heart failure and other conditions. that hypertension with heart conditions classified to heart failure, myocarditis, other ill-defined heart disease, and unspecified heart disease is assigned to a code from category I11, hypertensive heart disease. And then we'll use an additional code to identify heart failure or complications of heart disease. Then it goes on to include that hypertension with heart conditions classified to myocardial degeneration or cardiomegaly are also assigned to a code from category I11. But in that case, we would not assign that additional code to identify the heart condition. So we wouldn't necessarily code the cardiomegaly, we would just code the hypertension with heart disease. And then, of course, this guideline does say that if the hypertension and condition is not related, we would code them separately. And then the other guideline in the circulatory system is just regarding hypertensive heart and chronic kidney disease, where they're changing the wording from kidney involvement to chronic kidney disease to more closely correlate with the title. Okay, so diseases of the musculoskeletal system, we have a new guideline that's consistent with the general coding guideline that states codes describing specified sites are assigned individually by site when documented. When the specified site or sites are not documented, assign the appropriate code for multiple sites. So that is consistent with the new general coding guideline and is found in the musculoskeletal system. We have a few revisions in chapter 21, most notably under body mass index, which has new information clarifying that when the documentation reflects fluctuating BMI values during the current encounter, assign a code for the most severe value. And this could have implications on CC reporting, because if the patient's BMI is above that 40-point range, that would be a CC. And finally, just the last one is moving sequence. This newborn and infant guideline used to be number 12 and now is number 16. No real substantive changes there. Okay, so now we will go ahead and cover the ICD-10-CM changes. So there are new diagnosis codes and subcategory expansions that we will cover. And we've included certain key instructional note changes here. And then we will show you the tables to go to for the complete list of changes. So, for example, we will cover the new code for chronic viral hepatitis. You can see listed here B18 with no hyphen after it. That means this is just a standalone code. And for this one, of course, we will code additional code for ascites, which could be a potential CC. And then we have new subcategories under B88.0 for other acariasis for infestation of by Demodex mites. So you can see this subcategory has a hyphen after it, and that is the indication that it has been a subcategory expansion. We do have the new code for the malignant inflammatory neoplasm of breast, which has become a newer condition that's been diagnosed. Of course, chapter 4, we have the new type 2 diabetes in remission. And I did want to cover this E88.14 HIV associated lipodystrophy. So this lipodystrophy, not elsewhere classified, has expanded to include some subcategories. And this is one of them. I wanted to point this out because we will code first any HIV disease. So when we were just covering the HIV related coding guidelines, it was talking about anytime a patient is diagnosed with an HIV associated illness, we will then use code B20. And then you can see here that is listed in the instructional notes. For our neurologic disorders, we have a couple of new codes here: primary progressive apraxia and limb-girdle muscular dystrophy due to fukutin-related protein deficiency. And then multiple sclerosis has been subdivided into categories to describe the type. We have a few additions to the diseases of the eye and adnexa. We talked about that Demodex mite infestation. And then here's a new one for thyroid orbitopathy. So thyroid eye disease has been a new condition that has had some advances in medical treatment. So they have a new condition or a new code for that. And then let's take a look down in the diseases of the skin and subcutaneous, where categories L02.2 and L03.3 for the abscess and cellulitis have expanded to include the flank. And then for non-pressure chronic ulcers of the skin, that has also been a subcategory expansion to include specific sites of the abdomen, chest, neck, face, and groin by severity. So this is really great because before that, if a patient had a non-pressure ulcer in any of those sites, it was just that non-specific code. And then for the non-pressure chronic ulcers of the upper limb, we have a new code with multiple sites because of that new coding guideline. Okay, so we also have a couple new diseases here, the acute nephritic syndrome and the nephrotic syndrome with ICMPGN. So this is an immune complex disorder that attacks the filters of the kidney and causes glomerulonephritis. And then we have hereditary nephropathy, not elsewhere classified. A few subcategory expansions in the congenital malformation and abnormalities. One of them includes Usher syndrome. We do have a new code block for neurodevelopmental disorders related to specific pathogenic variants. And then in the signs and symptoms, we have for abdominal pain, they've added multiple sites to that for that code. For tenderness and pain, they've added the flank to that. Cannabis hyperemesis syndrome, that is a new code this year. And then for the injuries and poisonings, the abdominal injury classification sites have expanded to include the flank and the groin. And then we have a couple new poisoning and adverse effect codes. Anaphylactic reaction due to food has been expanded to include types of foods, as has other adverse food reactions. Then a couple external causes of morbidity here, and a few factors influencing health status and contact with health services that have been expanded. And then, of course, for a complete list of codes, conversion tables, and the final addendum, we've listed the website here. It's also in our resources page. All right, so that is the end of the diagnosis code changes. So now we will cover the ICD-10-PCS changes. So for fiscal year 2026, most changes occurred in the new technology codes, which had 54 of the 156 new codes and had 2 new tables. Overall, the procedure code totals show a net increase in codes from 2025, and there are 2 new medical and surgical section tables. So you can see here in this update summary the various sections and the number of codes in those sections. So the first table we will look at is a new med-surg table for 09X for transfer of the ear, nose, and sinus to include nasoseptal flap graft procedures. So that nasal septal flap is a mucosa-based flap supported by a vascular pedicle in the nasal cavity. And you can see our graphic to the right shows you that vascular pedicle. And so this would be the area of the nasal cavity that would be used to reconstruct anterior skull base defects. And the advantages are that it can be harvested endoscopically without the need for a second incision. And it does give broad coverage of most anterior skull base defects. So many times the reason we see an anterior skull base defect is because of removal of a tumor, and then they will cover that defect with the nasoseptal flap. The next one is not only a new table, but also includes a body part character definition change. So we'll cover that first. So the body part for the larynx, we have added in the cricoid cartilage and cricothyroid membrane, and then deleted that from the trachea. And then we have this new table for bypass of the larynx. So you can see here a cricothyroidotomy is a surgical procedure where an incision is made through the skin and cricothyroid membrane to establish an airway. And you can see here that incision is in the section of the larynx, because the cricothyroid membrane is part of the larynx, not the trachea. It does extend from the epiglottis to the lower border of the cricoid cartilage where the trachea begins. So thus a cricothyrotomy technically bypasses the larynx and not the trachea. We have a couple new technology tables, XDJ, to identify the use of ingestible capsules with light absorption sensor for use in inspecting the upper gastrointestinal tract, and table XHH to identify the insertion into the chest subcutaneous tissue and fascia of an ultrasound transmitter and battery for an endocardiac pacing electrode. So that covers the PCS changes that we are going to cover. So we covered the new tables, some of the new codes. Of course, there are a lot more codes than this. but we can't cover them all in the time we have allowed. Okay, so next we will cover MS-DRG changes. So the MS-DRGs have been adjusted to reflect costs for certain diagnoses or procedural technologies. And that's usually why MS-DRGs change. So DRG 077 to 79 for hypertensive encephalopathy have been deleted. And that PDX has been reclassified to DRG 070 to 072. And those do have higher relative weights than the original hypertensive encephalopathy DRGs. So that is a positive. For diseases in the circulatory system, we have a couple new DRGs to identify advances in procedural technologies, including 209 for complex aortic root or arch procedures. You can see has that nice high relative weight of 11.3188. New DRG 213 for endovascular abdominal aorta and iliac branch procedures for relative weight 5.7069. And so we will talk in a moment, but one of the procedures that was discontinued as a NTAP has been built into this DRG to establish the cost center there. We have DRGs 294 and 295 for deep vein thrombophlebitis that have been deleted. And then 35 of those diagnoses have been reclassified to DRGs 299 to 301 for peripheral vascular disorders. And several DRGs here regarding percutaneous coronary atherectomies. So DRG 318 is the coronary atherectomy without intraluminal device, so without a stent. Then we have DRG 359 is the percutaneous coronary atherectomy with intraluminal device with MCC. And then 360 is with intraluminal device without MCC. And then for diseases of the musculoskeletal system, DRG 509 for arthroscopy has been deleted. Those procedures that were previously classified here have been reclassified to separate DRGs that include arthroscopic procedures specific to the anatomic site. And that more closely aligns with the body system classification. Okay, we do have some revised MS-DRG titles. You can see the old titles on the right and the new titles on the left. For DRGs 23, 67, 68, 70, 71, and 72. So where they used to be non-specific, they are now either pre-cerebral occlusion or other cerebrovascular disorders. And these 070 through 072 are the, excuse me, DRGs that the hypertensive encephalopathy have been reclassified to. Okay, here is the MCC designation additions. You can see the acute nephritic syndrome with that idiopathic immune membranoproliferative glomerulonephritis that we talked about a little earlier. And an addition of all of those abdominal injury at the flank So all of these are new because we've added that body part flank. Then we have CC additions, including new and existing codes and subcategory expansions. Abscess and cellulitis and lymphangitis of the flank. Those new non-pressure chronic ulcer of skin, where they have subdivided that category to include sites. Those are also CCs, as well as the multiple site for non-pressure chronic ulcers of the upper limb. We have some congenital malformations here. That new Usher syndrome subcategory is in here, as well as those neurodevelopmental disorders. Okay, with that, we have another polling question. I'm going to hand it back over to Beth.
Okay, great. This poll asks, does your organization plan to perform pre-bill audits to identify missing NTAPs as part of its revenue integrity efforts under the fiscal year 2026 IPPS? And the answer options include yes, we have a defined pre-bill audit process specifically to identify and capture NTAPs, or in progress, we're developing or refining our processes to audit for missing NTAPs, or no, we do not currently have audit for missing NTAPs prior to billing. And lastly, not sure. I'm not aware if our organization conducts this type of review. So we'll pause for a few minutes just to allow the results to tally. We've got some pretty fast movement here. Now it seems to have slowed down. So we can probably go ahead and end the poll. And there's an outstanding outlier and not sure. Most of the response have leaded toward, I'm not aware if our organization conducts this type of review. Thanks so much for participating. Back to you, Lynette.
All right, great. Thank you. So speaking of NTAPs, we will now talk about our NTAP updates. So let's just first do a little introduction what NTAPs are. So these are special payment adjustments that provide additional reimbursement for using newly approved medical technologies that are not yet fully reflected in the MS-DRG payment rates. And the goal is to encourage early adoption of these innovative treatments, drugs, and devices by helping offset the cost until data can be collected to incorporate them into the standard MS-DRG payment system. So we've just briefly talked about some of those new MS-DRGs that were created because of some of the new technologies. So that would be an example where old NTAPs that were discontinued have now been built into an MS-DRG. So NTAP criteria must be met. There are 3. So the technology must be new. That's typically within 2 to 3 years of FDA approval or market availability. Must meet the cost criteria. So it must be significantly higher than the MS-DRG payment amount. So meaning the existing reimbursement does not adequately cover the cost. And it must show substantial clinical improvement in patient care compared to existing treatments in terms of better outcomes, fewer complications, and improved diagnosis. Now, there are alternative pathways that new medical services and technologies can qualify for NTAP. So one are breakthrough devices. So these are specifically devices that are on the FDA's breakthrough device program and are being used for the indication covered. Then the other one are qualified infectious disease products, or QIDP. And these are those designated by the FDA as a QIDP, or those approved under the FDA's limited population pathway for antibacterial and antifungal drugs. And these two pathways don't require for the technology to fully meet those three criteria that we just were discussing. So some of the best practices. First, of course, we need to identify what new technology is going to be utilized by your organization. There are folks in your organization that can help with this, such as charge master specialists, anybody in patient financial services, pharmacy, surgical supplies, surgical services. So lean on those folks to help you identify what is being used. Then, of course, we need to identify charges to be used for the NTAP. So sometimes these new technologies don't yet have CPT or HCPCS codes, and sometimes we can only just make a CDM charge that is not tied to a CPT or HCPCS. Then, of course, we need to locate the documentation in the medical record. So who is going to document the service? Is it going to be a physician? Where is it going to be documented? Is it going to be documented in a radiology report or in an operative report? And then we have to educate our coding staff on what new NTAPs are being used and how and where it's documented. So one of the pitfalls we have seen with NTAPs is hospitals get really excited about these new technologies and want to use them, but then fall short of reporting them. And many times that is because of documentation in the medical record. So that is a really key step in closing the gap on reporting of NTAPs, is making sure they're clearly documented in the medical record. So a couple updates here. We do have a new qualifier for new technology group 11 in the new technology section. And then again, not all new technology codes are eligible for NTAPs. And then you can see the MAC implementation file for details. So some of those discontinued NTAPs, that Gore tag, that procedure has been built into an MS-DRG. Cerament G for bone infection has been discontinued, as has the iFuse Bedrock and the EchoGo. So these are some really important new technologies that have now recently been discontinued. We have 27 continued NTAPs. A couple of them are high impact. We thought we would point out here this Lyfgenia with over $2.3 million of total impact, and Casgevy, which is over $1.6 million. We do have 26 new NTAPs, and I've got a couple of them highlighted here for you. Tecelra is an autologous T-cell immunotherapy for unresectable and metastatic synovial sarcoma with a price tag of over $472,000. So that's that max add-on payment. Breyanzi is a CAR T-cell immunotherapy with a $316,000 max add-on. And the Europa posterior cervical fusion system. This is an interesting one. It uses rhenium alloy and a rod, which is much smaller than what is currently available. And the pedicle screw tulips are really low profile, leading to less invasive surgery and less hardware prominence. but it does provide superior strength. So that's why that one meets. And its max add-on payment is over $80,000. So, of course, you will need to see that MAC implementation file 8 for the complete list, but we do have a snippet. So this isn't a snippet of the new NTAP tab. You can see on the right, many of these are in that alternative pathway status for breakthrough devices. And those are those NTAPs that didn't have to meet all 3 of the criteria that traditional NTAPs have to meet. Here is a snippet of the continued NTAPs. You can see a couple QIDPs in here too. And then a snippet of those 12 discontinued NTAPs with some of those breakthrough devices. All right, with that, I am going to hand it over to Charlie to talk to us a little bit about Evaluator.
Thank you, Lynette. All right, so I understand we just covered a lot of information, and so that could be a lot to take on for all of you. I know there are some of you that are familiar with technology, our technology evaluator. Some of you may not be familiar with that, but if you do have a technology like Evaluator or similar, that can help you with these updates. Here at MD Audit with Streamline Health and our technology evaluator, we provide these updates for you as far as managing and helping you manage those changes that you're seeing, as well as helping you add new NTAPs and the likes if it's viable for your organization. So what is Evaluator? I just want to give you a quick brief overview of what Evaluator does. So Evaluator is a pre-bill technology that's going to automate analyzing 100% of your encounters after they are final coded. And what we do with that is in real time, we are able to ensure that every code is accurate, compliant, and optimized to create a workflow for your auditors to review the ones that may have an opportunity for change. It helps prevent under and overcoding errors and reduce revenue leakage, leading to revenue integrity and optimizing those claims. We also utilize AI to enhance our algorithms and rules engine that is going to help you optimize your audit workflow so that you are ensuring those claims are clean the first time around. Any questions about that, you can visit mdaudit.com or contact us to learn more. With that, I will turn it over for the next poll question.
Okay, great. So this poll is asking, would you like a subject matter expert to follow up to answer any questions or show you more of the Streamline by MD Audit product? We'll give a couple minutes for this.
And Lynette, we'll just keep this open, just
Okay,
so people can take their time filling that out.
great. All right. So with that, I think we might have time for a couple of questions.
Okay, we have a question in the queue that asks, how does the guideline discussing HIV in pregnancy, childbirth, and the puerperium affect MS and APR-DRGs?
Great. So as I talked about a little bit earlier, the category code for 098.7 for HIV disease in pregnancy, childbirth, and the puerperium is a CC diagnosis. Now, with that, it can impact the MS-DRG. So ways that it can impact that is if we have a patient who has HIV positive status, and that has been indicated to be considerably affecting patient care, then we would assign 098.7 plus the asymptomatic status code. And that 098.7 will give us a CC.
Awesome. Okay. We have another question. And this question asks, do you see increased CDI queries related to the coding guideline regarding prior diagnosis of HIV disease?
Oh, yes, definitely. So, AHIMA and ACTIS both have practice briefs regarding querying on previously documented information in the medical record. So, with that coding guideline that we were talking about, anytime a patient has been diagnosed with an HIV related illness, they are always forever more to be reported with B20 for HIV illness. Now, sometimes that information is only listed in a problem list and might not be addressed separately. And sometimes that can impact patient care, but we might not have very good documentation. So it is very helpful to look back at previous documentation to see if the patient was diagnosed with HIV-related illness. And we can query as long as we're setting those specific guidelines as far as querying for clinical validity. All right. So that is the end of our presentation today. Here are the resources that we used. The links are on the left, and then on the right are listed the data files. So those data files are going to be in the fiscal year 2026 tables. So that's that first link on the left at the top. And that's where you can find all of the MS-DRGs, the relative weights, the GMLOS, all the new codes, all the procedures, and any additional information related to NTAPs. So with that, we will go ahead and end the presentation. Thank you for joining today.